Imagine a single, like, tiny biological typo,
Right.
just a piece of genetic code accidentally flipped backward. And now imagine that microscopic error altering the course of global empires.
Yeah. It's wild to think about.
Because that is exactly what happened with hemophilia,
Wow.
famously known as the royal disease. It completely devastated the royal families of Europe in the 19th and 20th centuries.
Yeah.
And it's just this profound reminder to all of us of how fragile human biology can actually be.
It really is. And I mean, it sets the stage perfectly for what we are doing today because, well, while we don't often think about the fate of empires, we do think about the everyday reality of childhood.
Oh, totally.
Right. You picture a certain amount of inevitable chaos, scraped knees from falling off a bicycle.
Bumped heads.
Exactly. Bumped heads, the occasional bloody nose. It is practically a developmental milestone to get a little banged up.
Yeah, it is how kids learn about the physical world.
Ex-
And as parents or caregivers or, even just bystanders, there is this comforting, almost invisible expectation we all carry. We expect that when a child gets hurt, the body just handles it,
It just takes over.
right? You clean the scrape, you put a bandage on it, and underneath that bandage, this incredibly sophisticated repair system just silently goes to work. It's like a biological safety net.
But it is a system we completely take for granted, right up until it stops working.
And that is our mission for you today. We are decoding the high-stakes world of pediatric bleeding disorders. So this isn't just about kids getting bruised easily.
No, not at all.
We are going on a documentary-style deep dive into what happens when that fundamental safety net completely fails.
Right.
We are looking at a system breakdown that can turn, a normal childhood injury into a life-threatening crisis.
Think of this deep dive as a master class in biological plumbing and immune regulation.
I like that. Biological plumbing.
Yeah, because to understand the diseases, whether that's a genetic anomaly like hemophilia or a sudden terrifying immune misfire triggered by a common cold, you first have to understand the sheer mechanical elegance of how the human body keeps its fluid exactly where it belongs.
Okay, let's unpack this. Let's unpack that mechanical elegance.
Yeah.
Before we can play medical detective and figure out what goes wrong in these bleeding disorders, we really need a solid baseline.
Right, the baseline is crucial.
How should the body stop a bleed? Because I'm realizing, reading through the sources, it's not just a single simple action. It is a highly coordinated multi-step sequence.
Right. So the medical term for this overarching process is hemostasis. When a blood vessel is injured, three major processes are initiated almost simultaneously to arrest the bleeding and repair the damage. And honestly, the physics of it are brilliant. Okay, so the first step is all about the blood vessels themselves,
Wow.
the vascular events. Right. The very first thing that happens is a vascular spasm. The small arteries adjacent to the injury undergo a reflex constriction. The blood vessel itself literally clamps down.
Oh, wow.
Yeah, if you think about the physics of fluid dynamics in a tube, reducing the diameter of the tube drastically reduces the flow of liquid through it. The body is essentially buying itself time.
Okay, so if the damaged blood vessel is, say, a burst pipe in your house, the vascular spasm is like running to the basement and immediately turning off the water main.
Exactly.
It stops the immediate pressure.
A perfect analogy, but turning off the water main doesn't fix the hole in the pipe.
Right, you still have a broken pipe.
Exactly. And that is where step 2 comes in, which is the platelets.
So how do the platelets know where the hole is? Because they are just microscopic discs floating endlessly in the bloodstream. How do they realize, oh, wait, I need to stop and do my job right here?
It's all about the hidden architecture of the blood vessel. So the inner lining of a healthy blood vessel is incredibly smooth, right? It's designed to let blood slip past without sticking.
Like a nonstick pan.
Exactly like that. But beneath that smooth lining is a layer called the subendothelial matrix. When the vessel is torn, that rough underlying matrix is suddenly exposed to the flowing blood.
Oh, okay.
And it acts like a chemical signal flare.
And the platelets see that flare.
They do. The exposure of that matrix encourages platelets to adhere to the site, and when they stick, they undergo this radical transformation.
What do you mean?
Well, they stop being smooth little discs and become spiky, almost like tiny burrs. This allows them to clump together, to aggregate. They release chemical signals that call even more platelets to the area, rapidly building a physical barricade right over the hole.
Okay, so this is what we call primary hemostasis. It forms a platelet plug. But I'm seeing this described in the literature as an unstable plug.
It is entirely unstable. Returning to your burst pipe analogy, the platelets rushing in and clumping together, that is like frantically wrapping the leaking pipe in a thick layer of duct tape.
Duct tape. Okay.
Right. It holds the water back for a minute, and it's a great emergency response, but the pressure of the system will eventually blow it right off. You wouldn't trust it long term.
Which brings us to the ultimate, permanent fix, the coagulation cascade or secondary hemostasis.
This is the definitive step, and I mean, it is arguably one of the most complex chain reactions in human biology.
Oh, wait.
Oh, yeah. The body uses a sequence of enzymes, which we call coagulation factors, that circulate in the blood in an inactive sleeping state.
Okay.
When the alarm is sounded, the first factor wakes up and acts like a pair of biochemical scissors to cut and activate the next factor in line.
And it's a cascade, meaning it's exponential, right? It's not just a one-to-one reaction.
Precisely. One activated factor doesn't just wake up one more factor, it wakes up hundreds, and those hundreds wake up thousands.
Ah.
It is a controlled biological explosion that culminates in the creation of a protein called fibrin. This fibrin weaves a solid, durable, microscopic mesh completely over and through the fragile platelet plug.
So if the platelets are the duct tape, the coagulation cascade forming that fibrin is like the plumber finally arriving and putting a permanent metal weld over the break.
It is the permanent metal weld, and establishing that framework, the water main, the duct tape, and the metal weld is the master key to everything we are going to discuss today.
Because that's what breaks.
Right. Almost every pediatric bleeding disorder happens because either your duct tape is defective or insufficient, or your metal weld is broken.
So the body is either failing to patch the hole, or it's failing to seal the patch.
Exactly. And knowing which one is failing changes everything about how a doctor responds when a child comes through the door.
Which puts us right in the shoes of the physician. If you're a doctor and a child comes into the clinic or the ER with unusual bruising or bleeding, how do you figure out which part of that plumbing system is broken before you even draw a single drop of blood for testing?
Right. It seems like magic, but...
It seems like an incredible amount of detective work happens just by talking and looking.
Oh, absolutely. The clinical history and the physical exam are paramount. The clues are almost always there in the presentation. You just have to know how to interpret the biological story the body is telling you.
Okay, let's start with the history. Obviously, you want to know how long the child has been bleeding or how severely. But there are more subtle clues, right?
Absolutely. You want to know if there's a history of excessive bleeding following past minor injuries, like did they have a simple dental extraction that bled for 2 days?
Right.
Is there poor healing of superficial wounds? You look heavily into the family history, and you also look closely at the child's age and gender. As we will see later, gender is a massive flashing neon sign for certain genetic conditions.
But the part of the pre-hospital history that really caught my attention in the sources is the extreme focus on what medications the child took at home.
Yes.
It's not just about what a doctor might have prescribed. It's about what the parents might have given them for a fever before they even got in the car.
This is a critical point in pediatric care. The physician must rigorously investigate the drug history. They need to ask about exposure to toxins. They need to ask about traditional or herbal medicines.
Because those can interact.
Exactly. But most importantly, they have to identify if the child has been given aspirin or any other nonsteroidal anti-inflammatory drugs or NSAIDs.
And if you are listening to this, you probably have a bottle of aspirin or ibuprofen in your medicine cabinet right now. We think of them as totally benign. But aspirin fundamentally disables the very system we just talked about.
It does. Aspirin irreversibly impairs platelet function.
Irreversibly.
Yes. It chemically prevents them from becoming sticky and aggregating. It basically ruins the duct tape.
Wow.
So if a child already has an underlying, perhaps undiagnosed mild bleeding disorder, giving them aspirin for a standard viral fever can completely dismantle their already fragile hemostasis. It can tip them over the edge into a severe, uncontrolled bleeding episode.
That is a terrifying thought for any parent. Okay, so after taking this incredibly detailed history, the doctor physically examines the patient. And the presentation of the bleed itself tells a wildly different story depending on what is broken.
It really does.
Let's look at the first presentation. Mucosal or skin bleeding?
Right, so when a physician observes bleeding primarily on the skin and mucous membranes, they are looking for very specific visual markers. They might see petechia, which are tiny pinpoint red or purple spots on the skin.
They look almost like a rash, right?
Exactly. They look like a rash, but they're actually microscopic capillary bleeds. Then there's purpura, which are slightly larger purple spots, and ecchymosis, which are what we typically consider to be your standard larger bruises.
And you mentioned mucosal bleeding too.
Yes, so bleeding from the gums, sudden severe nosebleeds, abnormally heavy menstrual bleeding in adolescent girls, or blood in the urine.
So when a doctor sees a child covered in these tiny surface dots, the petechiae, or they have bleeding gums, that presentation points them down one specific diagnostic path.
It strongly suggests that the primary hemostasis is failing. The duct tape isn't working.
Okay.
This clinical picture is highly typical of either quantitative platelet disorders, meaning you don't have enough platelets, or qualitative platelet disorders, meaning you have them but they are broken.
Got it.
It can also point to a condition called von Willebrand disease, which we will definitely dig into shortly.
But then there is the second presentation, which feels much more sinister: deep tissue bleeding.
Deep tissue bleeding looks and feels completely different. We are talking about spontaneous bleeding into the joints, a condition called hemarthrosis.
Into the joints. Ouch.
Yeah, or bleeding deep into the skeletal muscles or into the internal organs like the gastrointestinal tract.
Let me make sure I understand the mechanics here. The actual location and style of the bleed gives away the exact biological mechanism. Like, why do broken platelets cause tiny surface dots, but a broken cascade causes deep joint bleeds?
It's a brilliant question of physical pressure. So think about the tiny, superficial capillaries of your skin and mucous membranes. The blood pressure there is relatively low, but they are subjected to constant microtrauma just from moving around.
Right, just from living.
Exactly. Your platelets are constantly patching hundreds of microscopic leaks all day long. If your platelets fail, those tiny surface leaks show up as petechiae.
Because the duct tape is missing for those tiny low-pressure leaks. But deep inside the body, the vessels are larger.
Exactly. Deep inside a muscle or a joint space, if a vessel tears, the pressure is much higher. A flimsy platelet plug might temporarily hold, but without the permanent metal weld of the coagulation cascade, the fibrin mesh, the plug will inevitably rupture under the internal pressure.
And the blood just keeps leaking out into the enclosed space of the joint.
Yes. So, distinguishing between a petechial rash and a massive blood-filled knee joint is the crucial first fork in the diagnostic road. Deep tissue bleeds scream that the metal weld is failing.
And while evaluating these bleeds, the doctor isn't just getting tunnel vision on the bruise, right? They're looking at the entire child.
Always. You have to check for systemic signs. Is the child losing weight? Do they have a fever or jaundice? Do they have an enlarged liver or an enlarged spleen?
Hepatomegaly or splenomegaly?
Right. Because a bleeding disorder can sometimes be a secondary symptom of a much larger systemic disease like leukemia or a severe liver condition. You have to ensure you aren't missing the forest for the trees.
So, through the history and the physical exam, the doctor builds a strong working hypothesis. They think, okay, this looks like a platelet issue, or this looks like a cascade failure.
Right.
But they need proof. They need to actually see the invisible machinery at work.
Yeah.
How do they test that?
This is where we move into the diagnostic lab workup. The hypothesis gets put to the test. Modern medicine has developed an array of tests to assess the integrity of every single component of that plumbing system.
It usually starts with a complete blood count, a CBC, and looking at a peripheral blood smear under a microscope, right?
Exactly. The CBC gives us the raw numbers. It rapidly determines the exact platelet count and tells us the degree of anemia if the child has lost significant blood.
Okay.
But the peripheral blood smear is where a pathologist actually looks at the physical blood cells smeared on a glass slide.
And they can tell a lot just from the shape,
Yeah.
right? It's not just counting, it's looking at the morphology.
Oh, absolutely.
Hmm.
First, the smear allows them to definitively rule out leukemia, which is an absolutely vital step when a child presents with mysterious bruising.
Oh,
But looking at the platelets themselves is fascinating. You can actually see the biological factory errors.
because the size of the platelet tells a story about how it was made.
Yes. For instance, in a condition called Wiskott-Aldrich syndrome, the platelets are abnormally small. It's a genetic defect in how the cell builds its internal skeleton.
Oh, wow.
On the other hand, in Bernard-Cillier syndrome, the platelets are unusually large giant platelets. The factory is basically spitting out oversized, malfunctioning units. Observing that shape instantly narrows down the diagnosis.
Okay, so that evaluates the platelets, the duct tape. But what about testing the permanent metal weld, the coagulation cascade? There is an absolute alphabet soup of tests here in literature. PT, APT, TT. Let's make sense of these.
Yeah, it can be confusing. The easiest way to understand these tests is to picture that cascade as a complex factory with two completely different assembly lines that eventually merge into one final packaging line.
Okay, I like this. 2 starting lines, 1 finish line. Let's look at the first test, The prothrombin time, or PT.
The PT essentially tests the first assembly line, which we call the extrinsic pathway. It specifically evaluates a set of Werker's factors 10, 7, 5, prothrombin, and fibrinogen.
And instead of looking at normal lab ranges, we should think of these tests as biological timers. Like, how fast can this assembly line finish its job?
That is exactly what they are. The PT timer is remarkably fast. Like a biological sprint, a healthy extrinsic pathway can form a clot in a test tube in roughly 10 to 14 seconds.
That is fast.
Yeah. If it takes longer than that, we know something on that specific assembly line is broken or missing.
What causes that line to slow down?
Well, we often see a prolonged PT in systemic conditions. For example, if a patient has severe liver disease, the PT gets very slow. Why? Because the liver is the factory building that produces almost all of these coagulation factors. If the liver is sick, the whole assembly line shuts down.
That makes perfect sense. Then there is the second test, the APTT, the activated partial thromboplastin time.
Right. While the PT evaluates the first line, the APTT evaluates the second assembly line, the intrinsic pathway. This test is checking on a different crew of Werkers, factors 8, 9, 11, and 12.
And this timer's a bit longer, right? A normal APTT takes about 30 to 40 seconds.
Yes, and if the APTT timer is prolonged, but the PT timer is perfectly normal, the doctor knows immediately that the issue is isolated exclusively to that second assembly line.
Because the first line passed its sprint test.
Exactly. An abnormally long APTT is the classic defining hallmark of hemophilia.
Okay, so we have the two starting lines tested. What about the finish line?
That is the thrombin time, or TT. It tests the final stab, the final packaging line where fibrinogen is converted into that solid fibrin mesh.
And what if that is broken?
If the TT is deranged, we are looking at massive systemic failures, like a condition called disseminated intravascular coagulation, or DIC, where the body's clotting system essentially goes haywire and consumes all of its own materials.
Right, so if the liver is sick, the entire factory slows down and all the timers are prolonged.
Correct.
But if we see a child who has perfectly normal platelets, a perfectly normal PT timer, but a massive delay on the APTT timer, the doctor is staring down the barrel of a highly specific genetic missing link.
Exactly. That precise combination of lab results and isolated breakdown in the intrinsic pathway leads us directly to the most famous of all bleeding disorders.
Hemophilia, the royal disease. It is incredible how a single broken protein can cause such devastation. Let's get into the specifics of this.
Yeah, hemophilia is a brilliant, albeit tragic, example of genetic consequence. Let's start with hemophilia A, which is the classic form. It accounts for the vast majority, about 85% of all hemophilia cases, and affects roughly 1 in 5,000 male births.
Okay.
And the specific biological failure here is a profound deficiency in factor VIII.
Factor VIII, which is one of those crucial workers on the APTT assembly line. And you mentioned male births specifically. The genetics of this condition explain why it overwhelmingly targets boys.
Hemophilia A has an X-linked recessive mode of inheritance, meaning the defective gene, the broken blueprint for factor VIII, is located exclusively on the X chromosome.
Let's break that down for the listener. Females have 2 X chromosomes, so if one of those X chromosomes carries the typo, they have a backup. Their second, healthy X chromosome can usually step in and produce enough factor VIII to keep them safe. They become carriers.
Right, but males only have 1 X chromosome inherited from their mother and 1 Y chromosome from their father. They have no backup.
So if it's broken, it's just broken.
Exactly. If their single X chromosome has the mutation, they have no capacity to produce factor VIII. They suffer the disease.
But what exactly is the typo? What physically happens to the DNA?
Well, the most common genetic defect causing severe hemophilia A is known as the inversion 22 mutation. It is fascinating. During cellular division, a massive chunk of the DNA sequence literally flips upside down and reinserts itself backward into the chromosome.
Oh, wow.
Yeah. So when the body's cellular machinery tries to read the blueprint to build factor VIII, it reaches that flip section, reads gibberish, and simply aborts the process. The protein is never made.
That is incredible. A microscopic reversal causing a total system failure. Now, you mentioned female carriers usually have a backup X chromosome, but biology is rarely that simple, is it?
Biology loves throwing a curveball, and in this case, it's a phenomenon called the lionization effect. To prevent females from getting a toxic double dose of all the genes on the X chromosome, the body employs a radical strategy.
What does it do?
Very early in embryonic development, inside every single cell, one of the 2 X chromosomes is randomly, permanently crushed and inactivated.
Wait, so a female carrier isn't just blending the 2 chromosomes, she is a mosaic. Some of her cells are exclusively using the healthy X, and some are exclusively using the mutated X.
Precisely. It is a roll of the dice in every cell. And if, purely by random chance, the embryo happens to inactivate a large majority of the healthy X chromosomes, that woman will actually be left with very low levels of factor VIII herself.
So she could have symptoms.
Exactly. She won't have severe hemophilia, but dismissing her as an asymptomatic carrier is clinically dangerous. She might experience incredibly heavy menstrual periods or face severe, life-threatening obstetric bleeding during childbirth.
That is such an important biological nuance. Now let's talk about what hemophilia actually looks like in a patient, because I think movies and pop culture have given us a very distorted view. Let's bust a massive myth right now. Patients with hemophilia do not bleed more rapidly than anyone else.
Yes, it is the most common misconception. If a child with hemophilia gets a paper cut, the blood does not come gushing out at a higher pressure or a terrifying speed. The initial bleeding rate is completely normal.
Because their vascular spasm and their platelets, the watermine and the duct tape work perfectly fine.
Exactly. The issue is not the speed. The issue is the duration.
Yeah.
Because they completely lack factor VIII, there is a profound slowing of the rate of clot formation. The final metal weld never arrives.
So it just keeps going.
Right. So that paper cut, or worse, a minor internal injury that a normal person's body would silently repair in 5 minutes, just keeps leaking. It is a relentless, slow leak that goes on for hours or even days, eventually causing massive internal destruction.
It completely changes how you imagine the danger. It's not a sudden explosion, it's a creeping erosion. And the severity of that danger depends entirely on exactly how much or how little factor VIII they have in their plasma.
Yes, the clinical severity is directly tied to the numbers. A normal, safe baseline for hemostasis requires about 25 to 30 units of factor VIII per deciliter of blood.
But in severe hemophilia A, the levels are less than 1 unit. It is virtually zero.
And a child with severe hemophilia presents very early in life. The onset of symptoms is usually in early infancy. Doctors often first discover it due to prolonged, uncontrolled bleeding following a circumcision.
But the trauma isn't the only risk, right?
No. The most terrifying aspect of severe hemophilia isn't trauma, it is the spontaneous hemorrhage.
Bleeding with literally no injury whatsoever.
Yes. The normal, tiny microtraumas of just existing and moving are enough to cause bleeds. If a spontaneous bleed happens inside the skull, an intracranial hemorrhage is immediately life-threatening. But far more commonly, we see spontaneous hemarthrosis, deep bleeding straight into the joints.
And this isn't just about losing blood. The blood itself becomes a weapon when it's in the wrong place, right?
Blood is incredibly toxic to joint tissue. If a knee or an elbow fills with blood, the iron from the red blood cells and the intense inflammatory mediators completely irritate the delicate lining of the joint.
So it attacks the joint.
It essentially causes the joint to rust from the inside out. It leads to chronic synovitis, a permanent, hot, painful inflammation. Over time, this chronic inflammation literally eats away at the cartilage and the bone, resulting in crippling arthropathy. Without intervention, a child can completely lose the ability to walk or use their arms.
That is devastating. Now, there are lesser degrees of the disease. Moderate hemophilia, where the levels are between 1 and 5 units.
With moderate cases, the onset is usually a bit later, perhaps when the child is 1 or 2 years old and starts walking, falling, and bumping into things. Spontaneous bleeding is unusual here. The severe muscle and joint bleeds typically only follow actual physical trauma.
And mild hemophilia, where they have more than 5 units.
In mild cases, the disease might stay hidden for years. Age of onset can be anywhere from childhood all the way up to adulthood. They might only discover they have a genetic bleeding disorder when they get into a car accident or undergo a major surgery, like getting their tonsils removed, and the doctors can't stop the bleeding.
Right, because up until then, the duct tape was enough. We've talked entirely about hemophilia A, but there is a second version, hemophilia B, which historically has been called Christmas disease.
Yes, hemophilia B is caused by a deficiency in a different worker on the assembly line, factor IX. It is much less common, making up maybe 10 to 15% of all hemophilia cases.
But if a child walks into a clinic with a swollen joint, you can't visually tell the difference, can you?
Clinically, hemophilia A and B are completely indistinguishable. It is still an X-linked genetic disorder, it still causes deep joint bleeds, and it still drastically prolongs the APTT timer.
Yeah, you know.
The only way a doctor can tell them apart is by running highly specific chemical assays to see exactly which protein is missing.
But there is a difference in how the missing proteins behave, specifically their half-life.
Yes, from a management perspective, this is important. Factor IX has a significantly longer half-life in the bloodstream, roughly 18 to 24 hours.
So it sticks around longer.
Exactly. Because it sticks around longer before degrading, children with hemophilia B who require prophylactic infusions to prevent bleeds don't need to receive those infusions quite as frequently as children with hemophilia A.
Which brings us to the management of these conditions.
Mm.
Because you are dealing with a fundamentally broken system, the intervention has to be profound.
It requires a massive multidisciplinary effort. You need hematologists, specially trained nurses, orthopedic surgeons to monitor the health of the joints, physical therapists to maintain the child's mobility, and intense social support for the family.
But the core biological treatment is straightforward in concept. Replace the missing factor.
Right, factor replacement therapy. Historically, this meant giving patients actual plasma extracted from donated human blood. But this came with a tragic cost.
Right.
Because severe hemophiliacs require frequent, lifelong transfusions, they were constantly exposed to the blood supply. In the past, this meant they were at incredibly high risk for transfusion-transmitted infections, most notably HIV and hepatitis.
Which wiped out an entire generation of hemophiliacs in the 1980s.
It did. It was a dark era in medical history. This is why strict immunization protocols, like the hepatitis B vaccine, became mandatory. But thankfully, science has evolved. The gold standard of care today is the use of recombinant products.
Because there's synthetic factors, right? Grown in a lab.
Exactly. Scientists map the genetic code for factor 8 or 9, insert it into a cell culture in a laboratory, and the cells produce pure, sterile coagulation factors that have never touched human blood.
Oh, that's amazing.
It is. It completely eliminates the risk of transmitting those devastating infections.
And of course, the medical team will aggressively counsel against any medications that impair the platelets, like aspirin. You cannot afford to sabotage the duct tape when the metal weld is already broken.
Protecting whatever functional hemostasis the child has left is absolutely vital.
Okay, we just spent a lot of time talking about factor 8. But here is where the biology gets even more intricate. Factor 8 doesn't just float freely through the bloodstream on its own. It is highly unstable.
Very unstable.
It actually needs an armored transport to carry it around and protect it from being destroyed. And that armored transport introduces us to an entirely different bleeding disorder, von Willebrand disease.
Yes, von Willebrand disease, or VWD, is an incredibly important piece of this puzzle. It is actually the most common inherited bleeding disorder in the world. Current data suggests it affects approximately 1% of the total human population.
1%. That means millions of people are walking around with this genetic typo right now.
Yes, though many cases are mild enough that people live their whole lives simply thinking they are easy bruisers. The pathogenesis here isn't a missing coagulation factor. It is a deficiency or a defect in a massive complex protein called the von Willebrand factor, or VWF.
And what blows my mind is the elegant dual role this specific protein plays. It is doing two completely different life-saving jobs at the exact same time.
It is the ultimate biological multitasker. First, it plays a vital role in primary hemostasis, the creation of the platelet plug. When a blood vessel tears and exposes the underlying matrix, the von Willebrand factor binds to that matrix. And when it binds, the physical force of the blood flowing over it causes the protein to uncoil and change its shape.
Like deploying a grappling hook.
Exactly like a grappling hook. It uncoils and exposes sticky receptors. Platelets floating by in the fast-moving blood snag onto those grappling hooks. It is the molecular glue that anchors the duct tape to the broken pipe. Without VWF, the platelets just slide right past the injury.
But then it has its second job.
Its second job is in secondary hemostasis. It acts as the carrier protein, the armored transport for clotting factor 8. It physically binds to factor 8 in the bloodstream, protecting it from being prematurely degraded by enzymes, extending its life so it's ready when the coagulation cascade needs it.
So if we put this all together, VWF is the glue that makes the platelets stick. Indeed, it's the armored transport for the cascade worker. If you lose your von Willebrand factor, you are simultaneously sabotaging your duct tape and your metal weld.
And that is exactly why von Willebrand disease can be a nightmare to diagnose. It presents as a clinical paradox.
How so?
Well, because it ruins the platelet plug, the patient presents with mucosal bleeding petechiae, severe nosebleeds, bleeding gums, which looks exactly like a platelet disorder. But because it also causes factor 8 levels to plummet without their transport, it slightly prolongs the APTT timer, making it look a bit like mild hemophilia.
It's disguised as both. So how does it typically present in the real world? When do people usually figure out they are part of that 1%?
It heavily depends on the classification of the disease. There are three types. Type I is the most common, making up about 70% of cases. It's a quantitative issue. You produce normal VWF, you just don't produce enough of it.
Okay, and type 2.
Type 2 is a qualitative issue. You make plenty of it, but the grappling hooks are broken or the armored transport doors won't open.
And then type 3.
Type 3 is the severest form. It is autosomal recessive, meaning you inherited a broken gene from both parents, and your body produces absolutely zero von Willebrand factor. These patients experience severe, life-threatening bleeding.
But for the mild type I cases, the sources of discovery are usually things we consider normal life events. Heavy menstrual periods that are dismissed as normal for our family, or the classic scenario. A teenager goes in to get their wisdom teeth removed, a standard mucosal surgery, and they end up with significant postoperative hemorrhage that won't stop.
That dental chair is very often where mild VWD is finally unmasked.
So how does a doctor treat it? You can't just give them a factor VIII infusion like you do for hemophilia, because their body will just instantly destroy the factor VIII without the armored transport there to protect it.
Exactly. You have to address the VWF itself. For minor bleeds, doctors utilize local control techniques and strongly warn against aspirin. But for moderate bleeds or preparing a patient for surgery, there is a fascinating pharmaceutical intervention, a drug called desmopressin acetate, or DDAVP.
How does DDAVP work? I know it can be given as a simple nasal spray, which sounds incredibly convenient.
It is incredibly clever. DDAVP is a synthetic hormone. It doesn't actually contain any clotting factors at all.
Wait, really?
None. Instead, it acts as a chemical messenger. When administered, it travels to the endothelial cells, the cells that line your blood vessels, and commands them to instantly release their hidden, stored reserves of endogenous von Willebrand factor and factor VIII directly into the bloodstream.
It essentially pulls the biological fire alarm. It commands the body to dump every emergency supply it has into the system to stop a bleed.
That is the perfect way to visualize it. It floods the system with grappling hooks and armored transports, temporarily boosting the patient's hemostasis long enough to safely get through a dental extraction or a minor surgery, entirely avoiding the need for actual blood products.
It is a stunning medical workaround.
Okay.
So far on this journey, we've looked at inherited genetic blueprints gone wrong. Hemophilia and von Willebrand disease are typos in your DNA. You were born with them. But the landscape can shift suddenly. What happens when a perfectly healthy, genetically normal child's immune system suddenly turns against their own body?
This brings us to the realm of acquired bleeding disorders, specifically a highly distressing condition called immune thrombocytopenic purpura, or ITP.
A thrombocytopenia just means a low platelet count. We touched on the genetic versions of this earlier with Scott Aldrich, where the factory makes the platelets too small. But ITP is the acquired threat. It strikes children who were completely fine just weeks prior.
ITP of childhood is defined as an isolated drop in platelets without any other underlying systemic disease. And the hallmark of acute ITP is its sudden, terrifying onset, typically in children between 2 and 5 years old.
And the trigger for this is usually something incredibly mundane. In roughly 75% of cases, it is preceded by a standard, everyday viral illness. A cold, a mild stomach bug, or occasionally a routine vaccination, usually 1 to 4 weeks prior to the bleeding symptoms.
This is the core tragedy of the condition. A child catches a common respiratory virus. Their immune system mounts a brilliant defense, creates specific antibodies to hunt down the virus, fights it off, and the child recovers perfectly. But then, a few weeks later, the immune system experiences a catastrophic case of mistaken identity.
A biological cross-reaction.
Yes. The antibodies that were designed to target the virus suddenly begin inappropriately binding to the child's own normal, healthy platelets, identifying them as foreign invaders.
The immune system essentially tags the duct tape for destruction. And the drop in platelet numbers can be staggering. We aren't talking about a mild dip here.
Not at all. A normal, healthy platelet count is massive, usually between 150,000 and 450,000 platelets per microliter of blood. In ITP, we start watching the danger zones. When the count drops below 50,000, the child begins experiencing sudden, spontaneous bleeding episodes.
It gets lower than that.
Much lower. If the count plummets below 10,000 to 15,000, the child is in immediate danger of life-threatening internal hemorrhage, particularly bleeding into the brain.
The clinical presentation here is a paradox, because as a doctor examines this child, they don't look sick.
That is what makes it so jarring for parents. The physical exam is usually completely unremarkable. The child has no fever, no weight loss, Their liver and spleen are totally normal size. They're acting like a perfectly happy, energetic toddler.
But
But they look like they've been in a horrific accident. They're suddenly covered head to toe in petechiae, purpura, and massive dark bruises from entirely minor bumps.
because they have literally zero duct tape. Any microscopic movement tears a capillary, and there's nothing to plug the hole.
The diagnosis here relies heavily on proving that everything else is normal.
Yes, it is largely a diagnosis of exclusion. You have a toddler with a recent history of a cold who suddenly looks like a Dalmatian with purple spots.
Mm.
The doctor runs the lab work. The red blood cell count is perfectly normal. The white blood cell count is perfectly normal. The PT and APTT timers are perfectly normal.
Right.
The only abnormality is an isolated, severely low platelet count.
But what about the factory? Is the bone marrow broken? That is the crucial distinction. A bone marrow exam is typically not required to diagnose ITP unless the doctor is worried about leukemia. But if they did look at the marrow, they would see that the factory is actually working overtime.
So it's not a production problem.
Exactly. There is a normal or even increased number of megakaryocytes, the giant cells that manufacture platelets. The factory is pumping out massive amounts of duct tape, but the immune system's hit squads, the macrophages in the spleen, are intercepting the trucks on the highway and destroying the product before it can ever be used.
I can only imagine the terror of a parent in that clinic. Your totally healthy child is suddenly at risk for a spontaneous brain bleed just from walking across the room. But there's a massive silver lining here, isn't there?
There is. Despite how terrifying it looks, the prognosis for acute ITP is overwhelmingly positive. Approximately 90% of children recover spontaneously within 6 months.
90%.
Yes. In the vast majority of cases, the immune system eventually realizes its mistake. It stops producing the rogue antiplatelet antibodies, the hit squads stand down, and the child's platelet count naturally rises back to completely normal levels.
But a doctor can't just sit back and wait 6 months if a child's platelets are at 10,000. They have to intervene to protect the child during that acute danger window. How do you call off an immune system attack?
The management of severe acute ITP requires highly specific immunological warfare. You aren't treating a bleeding disorder, you are treating a confused immune system. One of the primary frontline treatments is IVIG.
Intravenous immunoglobulin G. They give a massive, overwhelming dose over 1 or 2 days. How does flooding a child's body with thousands of foreign antibodies stop their own immune system from eating their platelets?
It works by causing a massive distraction. Remember those macrophages in the spleen, the hit squads destroying the tagged platelets? The IVIG floods the spleen with millions of unassigned antibodies. The macrophages get completely overwhelmed. They gorge themselves on the IVG, essentially filling up all their receptors. They become so distracted and satiated by the IVG that the child's actual platelets are allowed to simply float safely by.
It is exactly like a fighter jet, deploying a massive cloud of chaff to confuse a heat-seeking missile. The missile locks onto the chaff, and the jet escapes.
A brilliant analogy. It induces a rapid, life-saving rise in the platelet count within days. The other major frontline weapon is a drug called prednisolone, which is a powerful corticosteroid.
And how does that work?
While IVG distracts the hit squads, prednisolone puts the entire military to sleep. It acts as a broad systemic immunosuppressant. It dampens the overall activity of the immune system, slowing down the production of the rogue antibodies at the source, and decreasing the appetite of the macrophages.
And if the jet chaff and the immune suppressants don't work?
There are refractory treatments, second-line drugs like anti-D antibodies or heavy immunosuppressants like cyclosporin, but they carry more significant side effects and are used cautiously.
There is also a very stern warning in the medical protocols.
Yeah.
Under no circumstances should a doctor ever give heparin or antiplatelet drugs to these children, which makes total physical sense. Why would you give a chemical blood thinner to a child who already has zero biological duct tape? It would be pouring gasoline on a fire.
It would be absolutely disastrous. It would drastically accelerate the bleeding.
We mentioned that 90% of kids get better on their own. The immune system resets. But what about the other 10%? The ones whose bodies refuse to stand down?
When severe thrombocytopenia persists for more than 6 months without resolving, the diagnosis shifts from acute ITP to chronic ITP. And when a child falls into this category, the medical approach has to become much more investigative and serious.
Because it might not be a simple post-viral glitch anymore.
Exactly. The physician must begin evaluating the child for deeper chronic autoimmune disorders. They have to test for conditions like SLE, systemic lupus erythematosus, where the immune system is broadly attacking the body, or chronic viral infections like HIV, which can also drive relentless platelet destruction.
But if they run all those tests, and it turns out to be truly isolated chronic ITP, just an endless, relentless attack on the platelets, how do you fix it? You can't keep a child on high-dose steroids forever.
You can't. Long-term steroids destroy bone density and stunt growth. While they might use supportive therapies like fresh frozen plasma during emergencies, the definitive treatment for severe, unyielding chronic ITP is a major surgical intervention, a splenectomy.
Removing the spleen entirely.
Yes, because the spleen is the physical headquarters where those macrophages live, where the antibody-coated platelets are trapped and slaughtered. Surgically removing the organ often completely stops the destruction. Studies show a splenectomy brings complete remission in roughly 64 to 88% of chronic ITP cases.
But that is a massive trade-off. The spleen isn't an appendix, and it's a job. It filters blood and fights off specific encapsulated bacteria. Removing it leaves the child permanently vulnerable to certain severe infections.
It is a heavy, calculated risk. It is only done when the daily risk of a spontaneous brain hemorrhage from having zero platelets outweighs the future risk of a bacterial infection.
It is incredible how these tiny elements, a single flipped genetic typo, a microscopic change in a protein's shape, a temporary viral confusion, can entirely derail the body's ultimate security system.
It really emphasizes the staggering delicacy of hemostasis. Every single factor, every platelet, every endothelial cell has to perform its job perfectly in the exact right sequence for us to survive the daily wear and tear of simply living our lives.
We have covered an immense amount of ground today. We started by exploring the sheer mechanical elegance of the plumbing system, the water main spasms, the unstable duct tape plugs, and the definitive metal welds of the coagulation cascade. We learned how doctors play biological detective, utilizing the physical pressure of the blood to distinguish between the superficial petechia of a broken platelet and the deep, joint-destroying hemarthrosis of a factor deficiency.
We decoded the factory assembly lines of the lab workup, understanding how the biological timers of the PT and APTT can isolate the exact missing worker in the cascade.
We looked at the genetic missing pieces of hemophilia, busting the myth that patients bleed faster and understanding the devastating reality of how blood can rust a joint from the inside out. We examined the brilliant dual role of the von Willebrand factor, acting as both the deploying grappling hook for the duct tape and the armored transport for the cascade. And finally, we navigated the terrifying sudden onset of immune thrombocytopenic purpura, watching the body deploy jet chaff to save its own cells.
It is a profound look into both the resilience and the terrifying vulnerabilities of the human biological machine.
It really is. And I want to leave you with one final thought to mull over. It's derived from that very last topic we discussed. We learned that 90% of children with acute ITP spontaneously recover within 6 months as their immune system realizes its mistake and gracefully rights itself. But 10% go on to develop chronic ITP. As the medical literature states, this happens for unclear reasons.
Yeah, it's still a mystery.
What exactly is the invisible, unresolved trigger in that 10% of children? What subtle genetic difference or hidden environmental factor causes their immune system to stubbornly refuse the ceasefire? Why does what should have been a temporary post-viral glitch turn into a lifelong, relentless siege against their own blood? We started this deep dive talking about how we expect the body's repair system to just silently work like an invisible safety net. But that 10% mystery is a stark reminder that beneath the bandage, there is an incredibly complex microscopic war going on, and we still have so much to learn about why, sometimes, the body absolutely refuses to lay down its arms. Thank you so much for joining us on this deep dive. Keep asking questions, keep pulling on those threads, and keep seeking out the knowledge that explains the invisible machinery of the world around us. We'll catch you next time.